Hello.
Hello.
It's good to see you both. Thanks for being here. Let's see if we can get Mosoka up here as well. While we're doing that, I'll just give brief introductions. Sheila Davis, you're the CEO of Partners in Health. Wonderful to see you here. Thanks for joining us.
Thanks so much.
Asia Russell, you're the Executive Director of Health Gap, and it's great to have you here.
Nice to see you.
And there's Mosoka. Hello. Mosoka Fallah works with Africa CDC. We're good. We're good. It's great to see you. And this is one of the people who's tasked with getting the African continents, getting African countries to their COVID vaccination targets. So we're delighted to have you here to share your perspective. And in fact, Mosoka, I'd love to start with you. Today we're talking about pandemic preparedness and really framing it around this question of, have we learned the right lessons from each successive outbreak that we've dealt with? I know that a really formative experience for you was the Ebola outbreak in West Africa. And I wonder if you could just share with us, based on the experience that you had then, 8 years or so ago, and the work that you're doing now, is the continent in a fundamentally different place today than it was when that outbreak really shook the world?
Thank you very much, Michael, for the question. As someone who was in the outbreak, I had just completed school in the US and returned and saw the devastation, the death, saw family decimated. And then I had to work with Ebola survivors and saw the number of orphans that I work with. I will say to you clearly that there have been some lessons learned, and it has helped in subsequent outbreak to reduce the outcome. And the way I like to illustrate this is where we had the initial outbreak was in Lofa, the northwestern part of Liberia. It shares border with Liberia, with Guinea and Sierra Leone. The first Ebola case came, of course, from Guinea. And obviously, because we had low system on preparedness, it ended up in Monrovia, a populated urban center. The result were 4,800 deaths and over 12,000 Ebola survivors. Push forward 2018 January. This is significant because this was around the time we were about to have inauguration. We had a second case, this time in the same place, but in the 3 countries. But within 24 hours, we were able to pick the samples, transport them to the lab, confirm the cases, deploy teams, and as a result, only 4 persons died. So in a matter of 2-3 years, same place, the same outbreak, different timing, different outcome. One with very limited death from meningitis. What was the difference? We have learned a painful lesson from Ebola that one, the ability to invest in diagnostics was critical. The ability to invest in public health workforce that are trained to detect disease and analyze diseases was critical. The ability, the need for logistics was critical. And so 2014, we never had that. From March to April, we had to take samples to Guinea or to Europe to be tested. And so as a result of the delay, we saw the consequences. But fast forward, we saw the same thing happening with meningitis, and we were able to continue the outbreak with only 4 deaths out of 9 cases. Finally, with COVID-19, the infrastructure built for testing was in place. And so with investment from Africa CDC, people were trained in Senegal, in Liberia, Sierra Leone, and they were on the spot ready to test the first case on March 16, Liberia and other countries. So having gone through the experience, whether in Liberia or in DRC Congo, following infectious disease outbreak, we've learned a lot. Even though there are still more to learn, there are still more investment that's needed. But the fundamental ability to invest in preparedness, response, and early warning has improved considerably. Thank you.
Fantastic. Mosoka, that's just a perfect jumping off point and a really powerful set of examples, I think, that ground this conversation in the reality that you're working in. Sheila, let me turn to you. I mean, I think when many of us think of Partners in Health, we think of Dr. Paul Farmer, we think of the powerful message that people living in poverty have just as much of a right to quality healthcare as anyone else. What does that mean within the context of pandemic preparedness, detection, response? How do you bring that philosophy to this specific set of issues?
Yeah, thank you. Such a good question. I think it's what we certainly know is that systems that are strong, so health system strengthening prior to a pandemic and having it ongoing, not just investing during disasters or pandemics, is the key. Because we had invested in West Africa, in Sierra Leone and Liberia, where we work, in oxygen systems, in hospitals, COVID, we were much better prepared, as my colleague was saying, but it can't be that it's only done during emergencies. It definitely has to be investing in a primary care health system for all the time. That is going to be a much cheaper alternative, certainly, and a higher quality, and also obviously the moral imperative to be treating people equally and providing quality healthcare for all.
That's great. Yes, thank you. And Asia, let me bring you in because we've had a great injection, I think, of optimism, and certainly there's a lot to be optimistic about. And yet, when we look at the experience of COVID-19, one of the big stories is a story of inequity. And you have been in this fight for equity for a long time, dating back to the sort of beginnings of the HIV epidemic. Are we learning lessons with each successive outbreak, or do you see the same sort of intractable patterns repeating themselves?
Unfortunately, I think the optimism that was just described, because of the leadership and expertise in West Africa just a few years ago, it's that bizarre contradiction and really hypocrisy that we see the infectious infrastructure, the pandemic preparedness infrastructure that both of you have spoken about as being the exception rather than the rule. That's preventable with money, with Africa being at the lead rather than being disregarded, with a setting aside of harmful policies, for example, monopolies giving primacy rather than sharing the recipes for vaccines, for treatments, for diagnostics that should be fundamentally public goods. So if we listened to the lessons from Senegal, from Sierra Leone, from Liberia, then we would be in a different circumstance. Instead, we have this bizarre contradiction where the President of the United States, despite the fact that 400 people are still dying every single day in the US from COVID, to say nothing of the thousands of counted and uncounted deaths all around the world, has said the pandemic is over because he wants it to be over. Now, magical thinking doesn't work to fight pandemics. What does work is exactly what our comrade just described from the front lines of the pandemic response to Ebola. So I think that's what we have. I mean, I'm not a pessimist. I'm pragmatic. I think we have to recognize.
I don't think pessimists can work in this particular
I think fundamentally what has to happen is we must wake up and recognize that without a push on the fundamental moral leadership so that billions of additional resources are raised, so that we prioritize expanding manufacturing capacity in Africa, finally, and so that we set aside harmful monopolies and other non-evidence-based policies and interventions that actually hold back an effective global response, then we will continue to be in the same vicious rather than virtuous cycle. I'm hopeful that we'll get to the virtuous place where we'll learn those lessons and we'll see them applied through the new systems that have been stood up, such as the Financial Intermediary Fund that's just been gotten off the ground, hosted at the World Bank. But I'm deeply concerned that instead we'll see more contradiction, more hypocrisy, more magical thinking from our elected officials.
Mosoka, I'm curious to get your reaction to that point, because you did direct us to these examples where institutions have grown in ways that enable them to respond really impressively. And yet, I wonder if you would agree that that is still not the norm in a lot of the communities where you're working, and what would be required?
So
Sorry, go ahead.
Like both my colleagues said, first of all, the mistake we make is that we do the investment in the midst of the outbreak. So then we spend a lot more in terms of, we come in with as firefighters, we spend more, but we do not avert the deaths and the long-term consequences. I just read an article, I think COVID is giving millions of orphans. As someone that had to work with Ebola survivors from the very beginning, with all of the clinical sequelae they had, the orphans, I know the deep-rooted long-term consequences they will face for the rest of their lives. And those could be reduced and averted if there's investment, early investment in the health system, in the public health system as well. But we tend to wait for emergencies and we move in. Secondly, let's take the case of COVID in Africa. When COVID began in Africa, there were only 2 countries that were capable of testing to diagnose COVID-19, South Africa and Senegal. It had to be some rapid activities by the Africa CDC to take men from the various countries and send them to the 2 countries, get them trained quickly and send back. Why if we never had that opportunity? We will have COVID in almost all of the countries without detection. And we do know in reducing the consequences of pandemic, detection is very critical. Then we detected the cases. We know the global shutdown in flights. African countries began to struggle with vaccines and logistics. Finally, it is sad to note that the entire continent of Africa, only 1% of the vaccines we manufacture. And we had funding, Africa City had funding, but they could not get diagnostics and vaccines because the Western nation let it first. So apparently we do not learn our lesson well, that early intervention in long-term broad health system, like developing the capacity to bring the manufacture of vaccines, medical countermeasure and diagnostics to the continent, to the proximate places that are needed, as a long-term ability to, if not prevent, but mitigate and reduce the consequences of pandemic. Because one will always say, in pandemic or epidemic, speed is everything. And to have speed, you must have the right manpower, the right capacity, and the right investment. But indeed, I will agree with them that inequality still exists, investments is skewed, and we wait for the emergency to spend more money than we would have done on a routine system. Thank you.
Mosoka, I don't know if you can see your fellow panelists nodding along, but I can tell you that they are. And this issue of investing or rushing in with money during a pandemic versus investing sustainably, consistently, and reliably over the long term, I suspect that resonates with you, Sheila, given that you work for an organization that I think is known for taking a more institutional approach. But again, I think the question is that still an aberration as opposed to the norm? And how do you get from point A to point B?
Yeah, I do think it's, there are certainly things to be optimistic about, but I think we definitely know that if we look at the US as example, our investment in global health is so low. Just yesterday on the House, Representatives Schakowsky, Lee, and Ruiz put forth the Paul Farr Memorial Resolution to say that we need to increase the U.S. contribution for global health from 12 billion to 125 billion a year because our aspirations are so low. So I feel like it is the exception. And during emergencies, there's so much attention. There's media. There's photo ops on the tarmac, and then everybody leaves. And I think we have to insist that there's long-term health system strengthening. We have to insist that pandemic preparedness is building a strong health system. It doesn't make sense to have a lab that is only there during emergencies, but that means the lab has to be maintained long-term, and we have to invest in human resources for health. We have our best early warning system for a pandemic is community health workers who are embedded in these communities in rural areas who will notice that their community is getting sick. That is a cheap investment. All community health workers should be paid for and should have a living wage, but that would be so much of a better investment. And I feel like if we all could work with the governments that we're working in the countries we are to move towards that, we would be much further along when the next pandemic, as it will, occurs.
The Biden administration, I believe, has also spoken about a health workers initiative and put some at least rhetorical weight behind that, but remains to be seen maybe if the money will follow. I know that there are folks in the audience here who are really passionate about the health workers issue. Asia, let me bring you in. either to respond to what you've heard.
Yeah, I mean, right now, the evidence could not be more clear that, for example, on the issue of frontline health workers, which, by the way, is a gender justice issue, it's a racial justice issue. Care economies are led by Black women all over the world. Let's be upfront about that. The PEPFAR is leading efforts to invest in living wages for community health workers, not because they want to, but because they were compelled to by communities as a leading edge of an effective HIV response. Instead of extrapolating those lessons and that evidence, we see empty rhetoric. We see this gesture from the Biden administration around community health workers, and then gridlock from Congress instead of full funding, because we cannot give more false hope to community health workers who have over and over again put their literal lives on the line and the lives of their families, only to be spurned when it comes to giving them a living wage. That's exploitation. It's unacceptable. It's not why anyone in Congress was elected. It's not why the Biden administration was put into power. To say nothing of other duty bearers from around the world. So the good news is we have the evidence. The bad news is it's not being applied, and in fact, it's being disregarded. And I want to come back to this critical point that was made about time, and whether or not we're learning the lessons, because exact time is of the essence. And during the early TikTok of the COVID pandemic, what did we see? I think it's very important to take a hard, exacting look. What we saw was hoarding. What we saw was a doubling down on nationalism, ineffective and racist travel bans. So until there's an accounting for the consequences of the lack of evidence-based response, we can't actually learn from our mistakes. And I think this point about hoarding is incredibly important, because the inclination makes sense. But when it comes to COVID, hoarding leads to more variants, not only moral decay. So we really have to create a recognition that the world has to be challenged to come together, not because we're do-gooders, but because that's the only way to get ahead of that very unforgiving clock ticking away every single time. So I think we can do that. I think, again, we need to reform and redirect some of the institutional weaknesses that exist. A volunteer-based response like COVAX does not work. Saviors will not get us out of this. Solidarity will. And the Africa CDC's work, for example, its inclination around a 30% earmark for continent-based manufacturing of essential commodities. That's a really important placeholder to come back to. And that kind of bold, ambitious, outside-of-the-box thinking has to be front and center as we deal with the pandemics of today and of tomorrow.
Mosoka, what would it take for you to feel like you were working in global solidarity with a community of international health leaders and institutions, as opposed to go ahead. Yeah, I think you know where I'm going.
No, go ahead, please complete. No, complete. As opposed to what?
Well, as opposed to wherever you find yourself today.
I mean, we published a paper recently, some group of African scholars on the inequity. So basically, we had a talk at Westchester University, and I had this statement long before Omicron. I said, as long as we keep on with this nationalism in terms of vaccines, extreme nationalism, hoarding vaccines, I said the West should do one thing: they should live on islands, create huge islands and live on those islands. That's the only way we can deprive a group of people with vaccines. But in the age of global travel, and it's as though the prediction came when Omicron started. And the interesting thing is that after Omicron, all of a sudden we have a new issue we got to deal with at Africa CDC. It's the issue of enormous donation of vaccines. But then we have a problem of demand, because the people the Irish Africans see a big contrast. When they were dying near the vaccines, they were hoarding the vaccines. And so they managed to survive in their own minds. And now we see so much surplus of vaccines. That's one. The second part is that we fought to advocate for the issue of intellectual property. We're advocating to start manufacturing in Africa, and some group of advocates and I sat together and wrote a position statement for the World Health Assembly. We couldn't have anyone to sponsor it. I reached this European country, a good friend of mine. He reached to the foreign ministry and came back to me and said, Mosoka, they are willing to assist you guys, but you have to remove the phrase that talk about the share of intellectual property, or else no one will go near you. We did not succeed in getting that advocacy on the agenda of the World Assembly. So we live in this world that is difficult. The way I say is, when people comfort gets threatened, they hoard. They isolate themselves from others, only at their convenience. But we live in a world that is so interlinked. And those that are involved in this work and do this work see the deeper suffering. We begin to ask ourselves, even in our own selfish interest, how do we build a collective world that we invest our resources in? That's going to be very critical. When I came to Liberia, there was this thought that community health workers should work for free. Everyone was telling me, give them a jacket, recognize them. And I started to say, as I went in the forest and other places, these people left their farms. They were only doing work. We were giving them multiple jobs, and we said we shouldn't pay them. These people are working more than 40 hours a week. When Ebola started, I started to pooch. It was one of those who put for $80 per worker. And I gave them the analogy and told them that you can spend less and we can continue with the Ebola outbreak for the next 2-3 years, or we can decide to respect these people and give them dignified wages, and we end this outbreak early as we can. So living in this world is it's complexity. We go to these Western schools and get one ideology. When it comes to the reality, it confuses some of us who have had the opportunity to go to the Western school. A poor farmer will say to me one time, Mosoka, you're in a unique situation. Your heart is in Africa and you are getting a brilliant education from Harvard. Your work is to bridge the two between your head and your heart. But when we try to bridge the two, the reality is that what we have learned in those big schools and the actual reality sometimes differs when we have pandemic and crisis to face of a global proportion. Thank you.
Sheila, last word to you. Let's talk about an opportunity. Where do you see a big opportunity to incorporate the lessons of the pandemic, of the outbreaks that we've seen, and to put ourselves in a better place?
Yeah, I do think if we are mobilizing around solidarity and holding each other accountable as well as our governments accountable, and not being socialized for scarcity, as Paul would always say, we're being socialized for scarcity on behalf of others. So deciding that it's okay that only 1 in 5 people in a low resource income setting has received one COVID vaccine, that's unacceptable. And I feel like only until we are speaking with one voice are we going to be able to hold people accountable and pushing on intellectual property and pushing on education and pushing on all of these things. But it's going to be impossible to do unless we're all united around on inequity as the issue that drove the pandemic and continues to drive inequity across healthcare.
Fantastic. Please join me in thanking our amazing speakers here. Thanks, Mosoka, for joining us. Thank you both for being here.